Greetings, cherished members of the Mighty Imaging Special Interest Group, and a special welcome to all our wonderful colleagues from the APT Orthopedic Academy. It's time for another Imaging SIG meeting with more encouraging news. Thanks for joining us in our collective efforts to dismantle the barriers that keep us from actualizing our ultimate macro picture goal of autonomous primary care physical therapy practice. And that for us in our drive to modernize our profession means realizing and normalizing physical therapist imaging referral privileges and PT-administered ultrasound imaging. I'm Bruno Steiner. I'm serving my second term and final 3-year term as president of the Imaging Special Interest Group for the APT Orthopedic. And just when it seemed the wave of supportive evidence might slow down for the summer, the APT's very own prestigious PT journal has delivered yet another seismic boost to our primary care aspirations, a monumental meta-analysis courtesy of our esteemed Imaging SIG colleagues and dear friends, doctors Dallas Ehrmantraut, Bremen Abuhl, and Mitch Walden. Their work has just been published as an editor's choice journal article, powerfully affirming the critical role physical therapists play in primary care and strengthening the case for PTs as first contact providers. It's entitled First Contact Physical Therapy Compared to Usual Primary Care for Musculoskeletal Disorders, a systematic review and meta-analysis of randomized control trials. And just to describe our guests, University of Jamestown's doctors Ehrmantraut and Abuhl are still celebrating North Dakota's victory for full MSK imaging referral privileges this year, and they remain vigorous agents for the modernization of physical therapy practice. It's an honor to have them give us a first look at the final data and the implications for physical therapists in North Dakota and the nation, if not globally. Maybe they'll even let us in on the next steps for the Rough Rider State and their future research ideas. I am max excited about this and for the future of our profession. Please stay with us tonight and welcome our guests for some new grist for the mill. And we certainly hope to hear from your perspectives, insights, and counterpoint as they present physical therapists as first contact providers. The meta-analysis data is in. Less imaging, few medications, same or better outcomes. But you know what I'm going to say? I can't wait to hear from our colleagues and dig deeper into the findings. But as usual, I've got to get through some business items for our Imaging SIG members and, of course, review our nation's PT-directed imaging scorecard, as well as our new PT-administered ultrasound imaging scorecard. And once again, we've got some really great developments for you and a total cause of celebration before we get to Bremen and Dallas. So onward, leading off, let's talk about the Mighty Imaging SIG membership meetings. Remember, if you want to check out our previous membership meeting recordings, just navigate to our Imaging Special Interest Group page on the APT Orthopedics website and scroll down to the very bottom of the page, and you'll find the iSig membership webinars and click your way to the growing inventory of meetings. And also check our APT Orthopedic YouTube channel for all kinds of our generated, produced content, including our membership meetings. And I must say, they continue to get a lot of views. And much to my amusement, people are actually setting alerts to be notified of membership meeting recordings. It's not an accident. This is mainly because imaging referral and PT-administered ultrasound imaging are so important and transformational to autonomous primary care practice, to our professional relevance, diagnostic accuracy, for expedient, modern, quality patient care. Our most recent entry is there, and it's been exceptionally well viewed. Our dear colleague and collaborator, Dr. Aaron Kyle, granted us a privileged first in-person presentation of a pivotal publication for the profession with his fellow investigators, Stephen Karaha, Kelly Clark, Evan Nelson, Brian Barney, and Scott Toffener. And that study, for your information, is entitled Ordering of Diagnostic Imaging by Physical Therapists, a Multi-Center Analysis of Successful Implementation. It's a must read. And this type of critical research is exactly what we need to defend modern physical therapy practice from false narratives generated and espoused by stakeholders within and without the physical therapy profession. I've said it before, I'll say it again. This is the kind of data that's going to be seriously impactful and inform public policy in a nation beset by crisis level and worsening physician and nursing shortfalls. You know it. I know it. Physical therapists are ready to practice at the top of their license for the public good. It is time to leverage modern physical therapy practice for the healthcare consumer. I mean, come on, put us in, coach. Creeping up not so slowly is APTA's combined sections meeting in Anaheim, California, February 12th to 14th. I know this seems premature, but time is freaking fleeting. I'm so happy that it's on the West Coast this year. Despite my love for all regions of the USA, living in Seattle, this is a short commute for me this time around. Distance notwithstanding, the pressure is on to represent the mighty Imaging SIG at CSM 2026. And our Imaging SIG VP Education, Dr. Brian Young, he's actually got some content cooked up. Is he around right now?
I'm right here, Bruno.
Oh, thank God. Uh, do you have a slide that you need to show us?
I don't have a slide. I didn't have
Okay.
a chance to do that. But our content this year is going to be provided by three amazing contributors to our Imaging SIG content. We have Lance Mabry. We have Alicia Markowski and our very own Chuck Hazel presenting at CSM next this coming spring, and we're going to continue with our imaging masterclass series, which is on elevating diagnostic imaging skills for DPT students, new graduates, and practicing clinicians. And so both of those kind of studies that you just talked about, Bruno, that are fresh on the presses coming out, and just data, very relevant to what we're going to do, just to really have our speakers bring about how we just really learn the skill sets to be stronger, to provide high quality, appropriate care for those that seek out physical therapists, knowing that we can make up that big impact. And so we're going to continue this line as we both move forward. So that's what's on the docket for our Imaging SIG sponsored CSM.
That is wonderful. Thank you so much for always providing such robust content and, of course, lining up guest speakers for the AIUM webinars that we participate in. More. I got another speaker, by the way, for that. I'll tell you later. Onward. Thank you so much. Um, you know me, I'm not going to let you off the hook. I'm just going to absolutely tell you you need to learn and use diagnostic ultrasound imaging. It's transformation of physical therapy practice. Incorporate it into your professional and academic lives and get involved in promoting it. Um, you know, uh, how do I love ultrasound imaging? Let me count the ways. Every time I think about it, I think I have this love sonnet in my mind. And of course, when they used to use ultrasound in the Elizabethan times, they were looking at hemarthrosis way back then in the 1600s. Not really, but this is what I got from our AI. So, anywho, and how could you not love ultrasound imaging? Here's this patient that actually was being cared for in wound management, kept on having it cleaned. This was right below a total knee replacement, something you can't throw into an MRI or CT without an enormous amount of flash artifact obscuring everything. My hematologist oncologist said, "Hey, can we ultrasound that even with an open wound?" And I said, "Sure, ultrasound gel is also sterile. Let's give it a whirl." Not ever having done, thought about this. Put it over, and here we have two foci that were eating into the tibia with a pretty rip-roaring power Doppler activity. Very nefarious. We sent it for further studies. We knew what it was, and it confirmed osteomyelitis. That clearly changed the trajectory for this patient and how we were going to care and manage it going forward. Just thought I'd let you know how cool ultrasound truly is. Um, what about the APTA? Well, the APTA has formally declared ultrasound imaging as part of the physical therapy professional scope of practice as a response from a direct inquiry from yours truly. And the AIUM, the American Institute of Ultrasound in Medicine, recognizes physical therapists as licensed medical providers of MUSCUS, and they offer all kinds of online ultrasound imaging content, and we actively provide content for them as well in webinar form. This has been a great relationship for us. We got some things, irons in the fire with them. We're really happy with them. We want to deepen our involvement with them because frankly, we need more venues for our publication. They run the Journal of Ultrasound Medicine, and we're making some great breakthroughs with them. And speaking of tremendously important synergies, the gold standard credentialing body Intellios and their registries recognize physical therapist eligibility for their certifications. And more specifically, we should all be taking advantage of the incredible privilege of sitting for the RMSK physician credential for muscus imaging, governed by Intellios's Alliance for Physician Certification and Advancement. Advancements, RMSK. And physical therapists continue to pass this exam alongside our physician colleagues, and we're really showing how we can go toe to toe with our dear colleagues in the other disciplines. And I'd be remiss, of course, if I didn't tell you to take advantage of their many POCUS Academies certifications, which physical therapists are explicitly invited to work towards, including cardiac, vascular, pulmonary, visceral, pelvic, and abdominal, and of course, MSK applications. They're a lot easier to work towards than the RMSK, but know that I want all PTs to go for the RMSK and, like I said, test our mettle alongside our medical colleagues. Now, I'd like Doug White, if you can weigh in. You've something interesting has come along from Intellios as an offering. Can you please address that?
Sure. So if you have the RMSK, you should have received an email from them asking them for you to participate in their practice analysis survey, which then they use to base the exam on. So I think it's really important that we have PTs contributing to that so that we can provide our own perspective on that. So if you did not get that email, certainly contact me. Or Bruno, you probably got it too.
Yeah.
And um, we can forward it to you if you missed it. The second quick thing I want to mention is we got the APTA position on diagnosis significantly amended in the House of Delegates a couple of weeks ago. It's a big improvement over what was there and will really support what we're doing in imaging. So that will be finalized and published in early September. So look for that.
Oh, how exciting.
And then the third thing is I just got an email this morning from Clarius. I don't know if other people get their emails or not, but we have a couple of PTs doing a webinar in the middle of August talking about incorporating ultrasound into DPT education. Student education. So look for that. You can probably find that on their website as well. It looks like a great program. The Belmont University PTs are doing that.
Wonderful news, and what a perfect segue to showing you a little something that we were just involved with in training DPT students at the University of Washington just this week. Much to Murray Maitland's, our deputy research chair. And this has been his vision to bring ultrasound. So I, along with another RMSK, Mark Krimmel, who works with me here at the Washington Center for Bleeding Disorders, we conduct this yearly workshop, and it was just absolutely fabulous. I wish Murray could speak to this, but physical therapy students, they take to this like fish to water. It's just the light bulbs are flashing the whole time. It's really impactful. They're very engaged, and this is something we can do and should be teaching, frankly. And to that point, I'd actually like to shift over to our research chair, George Bennick, and you've got some news for us that you'd like to share, no?
Oh, yeah. If I can brag a little bit about our program and what we do with ultrasound, we've been teaching ultrasound anatomy this is our fourth year now. So the students get about 12 hours of practice time doing ultrasound scanning. And as of last week, we just set up our first clinical that's going to have 5 to 10 hours a week of ultrasound scanning working with Cindy Bailey.
Oh, super. That's brilliant.
The other news is this is a job I've been putting off, but it was inevitable. Some of you may be familiar with, we have a research imaging mentor web page at the website. that we put together back. Tara was very helpful with that about 6 years ago. So that was just for anybody who's interested in using imaging as part of their research. They have a list of mentors that are specialized in certain imaging modalities as well as different body areas. And so they listed their contact information, how much mentoring they'd be interested in being involved with. And that we've had going for the last 6 years. So what we need to do now, and should have done earlier, is we need to start that up for clinical applications of ultrasound imaging and have a mentor list there that PTs that are wanting to get up and going and learning ultrasound have somebody that they can communicate with to get feedback from. So I'm working on getting ready to send out emails for that now. If you know of anybody that might be interested in participating as a mentor, you're welcome to send me their contact information. I have about 50 people already that I think might be.
Right.
Bruno, you know I'll be asking for you, and Doug as well.
I know. That's great.
That's all
Doug,
I got to report.
Yeah. Oh, that's great. Is that it?
Yep.
Right on. Doug, you had one last hand wave there from the emoji. Do you want to say something? You all good?
No, no, no. I was just clapping George's comments. That's all.
Okay, that's fair. Okay. Let's get on with it here. Okay, nationwide scorecard. Where are we with imaging referral privileges? I'm gonna do a quick rundown, and with that, I've got some pretty exciting news, frankly. And I want to make sure that this that I do reveal this. Dr. Lance Mabry and I continue to collaborate to compile and refresh this list. He's always at the ready to respond to all our calls to action, both support and leadership. So can't do it without all our collaborators. I want to start off with the military branches. I can't overstate the importance of our colleagues in the military services. The physical therapists serving in the military branches have no prohibitions on imaging referral and have proven the efficacy of PT-directed imaging since the 1970s, and it constitutes an important precedent and needs to be vigorously cited on every occasion. So this is what we want. This is where we need to go to. So anyways, nationwide imaging referral privilege. So this is a different map than it was a few months ago. Why? North Dakota, this is where our speakers are from. They've done a lot of work in advocacy to make this happen. They used to be in pale green, which represented states that could only refer for radiography. North Dakota has successfully and masterfully advocated and campaigned for a legislative approach to win full imaging privileges. I'm wondering, Mitch Wolden is here. A real surprise for me. Mitch was involved in this. I saw him testify at the state level. He is a master. He did such a phenomenal job. I would just like to roll tape on him just to show you how it's done, the art of decorum in addressing some recalcitrant legislators with just poise and professionalism. I can't say enough, Mitch. We got to talk because I really want to hear just how you guys built your campaign going forward. We could have Scott Brown as well. I was blown away. I really thought this was a study on how to do it right. Oregon, this is a big, big, big piece of news. Now they did what they called a Modernization Practice Act. It was a tough battle. This was a legislative initiative, and they tried to get imaging referral privileges and dry needling, and through another sort of parallel sort of legislative effort, get on the list of providers that are allowed to use ultrasound imaging. And there was such a battle with the acupuncturists. They were just a really hostile crew. They just espoused some really vicious, terrible narratives that were so uninformed. They were attacking our basically old physical therapy domains, like, oh, apparently they do wound management. This is terrible. I mean, it was just awful, very ill behaved. So they were really they had our advocates had their hands full, just even fighting for for dry needling. And because of that, I think this distracted from the imaging side of it, but they got dry needling. However, because of all these distractions, they got They're the first state that actually have physical therapists having won ultrasound imaging. I mean, this is amazing. We're actually able to do ultrasound imaging there. I mean, that is legislatively recognized. So this is a huge victory. It still remains neutral in terms of imaging referral, but we're going to win there too. It is my experience that you can wear down your stakeholders because frankly, they don't want to be there and they don't want to always say no. And you know, legislative campaigns and defending your turf, that's a hard business. All you got to do is outlast them and outfight them and just keep coming back, just like North Dakota showed you can do it. It's an incredible study on how to do it right. All right. So get an ultrasound transducer over to Oregon. Just to let you know, there's actually other states where ultrasound has been recognized as declaratory rulings. There's some seriously interesting things happening in North Carolina. I have to keep mum about it. I don't want to reveal too much, but I'm crazily excited about the progress being made to reverse a really terrible declaratory statement from their board. Apparently, there's been a complete turnover in their board. We'll see what happens. I am sure this exciting news will be imminent in the fall. Just to let you know, irons in the fire. Missouri's made an actual declaratory. They made a special inquiry with an extremely well-crafted question to the state board. They're awaiting a response. Maine is in that same process. I should have circled Vermont right next to it. Well, you know, it's partially circled. So Elizabeth Sargent, who's responsible for this, she's passionate, plus to the max. She wants this, and she is a strong advocate and champion for us. And we wish her luck in moving that forward. I have every confidence in the world. So really neat things. Also, just down the pipe, we have two advocates that are really, really effective and very passionate as well in Texas regarding imaging referral and doing an inquiry there. So just all kinds of stuff happening. So there you have it. Washington State, I am in talks with the National Consortium. We are in close contact. I want to get them. They've got 13 centers in Washington State. I'm trying to get them to, they want us, they want our patients from physical therapists. I'm just organizing. They're trying to get their language straight to make sure we can just start it, even though we're in a neutral, we're completely in a silent state on that, in that regard. So won't even need to do frankly, an inquiry to the state board. Now, this is for ultrasound. Look, the short answer is you can do it. There's no restrictions. Everywhere it's green, it's good. Alabama, whole nother story. I don't want to waste more time on Alabama, but you know, we'll talk about that language later. It's poor Alabama. Anyways, we don't need to go over that. I just wanted to let people know that in this recent wave of people getting RMSKs, our very own treasurer of APT, orthopedic chapter, Tim Brinker, got the RMSK. It's no easy feat. It's a capricious exam. It's difficult. And one of the advocates, very effective, Micah Wong, he's just great and advocating for ultrasound for Oregon. He just got his RMSK. And my colleague across the USA in Pennsylvania, working in bleeding disorders, Clayton Kubrick, got his RMSK, and there's so many more that got it. So I'm just super hyper proud. Now, I'll just remind you that I'm available to take all your questions offline if you want to discuss strategic planning for your individual states. And that's how you should look at us at the Imaging SIG, your rapid response resource. Don't plan it alone and reinvent a faultier wheel and a really crappy inquiry. The language is important. Please contact us. You can't just simply ask the question, is imaging in our practice act or is ultrasound imaging in our practice act? Don't ask it that way. Please just call us. We've already crafted the question. We'll make some tweaks to your state. Don't go it alone. Don't reinvent a faulty wheel. All right. To the main event. tonight, we're incredibly proud to invite two phenomenal standard bearers and ambassadors to our profession. Their meta-analysis will further inform our advocacy efforts going forward to help our interdisciplinary colleagues, stakeholders, state board members, and legislators, the benefits coming from physical therapists practicing at the top of their license. Everyone, please extend your warm welcome to Doctors Dallas Ehrmantraut and Bremen Abuhl, who will present a vision in which physical therapists become true partners in multidisciplinary care. Dr. Dallas Ehrmantraut is currently an assistant professor at the University of Jamestown Physical Therapy Program and a physical therapist at a primary spine care clinic at Sanford Health in Fargo, North Dakota. He graduated from the University of Jamestown Physical Therapy Program in 2020, completed an orthopedic residency in Sanford Health. Following that, and in the spring of 2021, he started teaching orthopedic content at the UJPT program, along with directing their pro bono services. Ever dedicated, he began pursuing his PhD in clinical research in the fall of 2023 with a focus on improving the value of healthcare. And not to be outdone, Dr. Bremen Abuhl, on a similar path, graduated from the University of Jamestown 24 and began the same orthopedic residency in August. And he's also a part-time provider at the primary spine care clinic at Sanford Health, evaluating and managing patients with complex neuromusculoskeletal conditions. He started his PhD in clinical research in the fall of 23 with a focus on clinical decision-making in primary care and medical overuse. Gentlemen, the floor is yours. I'm sick and tired of hearing myself talk, so I will unshare, and I am so happy to have you here. Take it away, guys.
Hey, thanks, Bruno. We're excited to be here. This is actually my second time presenting at one of these meetings. In December of 2024, Bremen and I were supposed to present together on this exact project before it was completed. Unfortunately, Bremen was sick that day, so we're excited to be back and present our completed project, the systematic review and meta-analysis that Bruno has done such a nice job of introducing up to this point. Hopefully it lives up to the hype. So let's get into it. We titled this PTs as First Contact Providers, looking at our research article specifically. I don't think we need to introduce ourselves anymore. Bremen and Dallas, both here in Fargo, North Dakota. Last time I came to you, it was probably around 0 degrees with 30-mile-per-hour winds and gusting or flying snow. So it's nice to come to you in the summer where it's a little warmer. It is a bit humid right now, but the joys of the seasons being here up in the Midwest. So yeah, Dallas and Bremen, we get to present to you this study, First Contact Physical Therapy compared to usual primary care for musculoskeletal disorders, systematic review, and meta-analysis of randomized controlled trials. Now, before we get into it, Bruno had also mentioned somebody who's on the video here, Mitch Wolden. Mitch is our third author, our advising author on this paper. Without his guidance through this whole process, we would not have been able to get it published. He is an excellent researcher. He's both Bremen and I's PhD advisor right now. And so we're super grateful for his guidance through this process. And as we continue to work through the PhD program with our specific areas of inquiry, Mitch has continued to help us along the way. So very thankful for Mitch's guidance, and he deserves a lot of the credit for this project because it wouldn't have been possible without him. So the objectives over the next however many minutes are to go through the literature review, what we were seeing before we conducted our study, and then to present our final research that was published. So I'll bring you through the literature review, and then Bremen's gonna bring you through the rest of it. But when Bremen and I came into Mitch Wolden's class, actually, we knew that we were gonna have to develop a systematic review for the PhD program. And so he and I both interested in first contact care, primary care, physical therapy. We were relatively new to the topic, so we thought, well, nobody's studied this before, so we might as well just do a systematic review on PTs compared to usual primary care. I'm sure there's nothing out there. Well, We came to know that that wasn't exactly the case. There have been other systematic reviews done in this area, including this one led by Simon LaFrance, who happens to be one of Bremen's PhD committee members. And so we kept looking and seeing if there was anything else out there. So it wasn't only this one, there was another one and another and another. And the list kept piling up until we came across 9 systematic reviews. And of those 9 systematic reviews, 2 of them included meta-analysis. So we needed to decide if there were still gaps in this realm. And if there were gaps, what were they and how can we address those? So what I want to do in the next slides is just highlight some of the specific outcomes that these other reviews investigated. And then after that, kind of tell you where we were at and why we chose to do what we ended up doing. So there were 6 systematic reviews that looked at health outcomes, and what they found was first contact physical therapy led to similar, if not superior, health outcomes when compared to usual primary care. Beyond health outcomes, they also looked at things like patient satisfaction. These 3 systematic reviews specifically looked at that and found that patients were more satisfied when PTs were practicing in these roles. One thing that we continue to learn about through our literature reviews and as we develop our different projects is the demand on these primary care providers and many times first contact providers in some specialty settings is extremely high. The AAMC has published several things on it. One of the more recent ones shows a shortage of 20,000 primary care providers right now, expected to double by 2036. And when we look beyond just primary care providers and look at all physicians across the board, they expect a shortage of 86,000 come 2036. So the demand is only increasing, and we know that people are getting older in the United States. We know that people are coming to the clinic with more comorbidities, and a lot of those are musculoskeletal disorders. So who better to offload these other providers than physical therapists? This specific outcome is very relevant with what we're going to be talking about tonight, healthcare utilization. These 4 systematic reviews look specifically at that, and part of healthcare utilization is clinical imaging rates. How often are these different diagnostic imaging procedures being used by different providers, but also things like more visits and more procedures being done. So these 4 systematic reviews found that PT in this role led to less healthcare utilization. Not only that, but probably not surprising, if we're using less services, it's going to be more cost effective. And these 6 reviews looked at cost effectiveness, and they found that first contact physical therapy is more cost effective than usual primary care, which is really important when we consider how much care costs for these different musculoskeletal conditions. And so it's encouraging to see that it is a more cost-effective route. And I know it's been studied before comparing physical therapy to usually primary care in a non-first contact setting, but we also see it in this first contact setting as well, where the PT is actually managing the patient care from the get-go rather than having a patient referred to them and treating them secondhand. So that's exciting to see. And then the most important thing, patient safety. Through all of this, there hasn't been one systematic review that identified a greater safety risk when seeing a first contact physical therapist compared to usual primary care. And that includes inappropriate imaging referrals. We know that diagnostic imaging is overutilized and sometimes in an unsafe manner, but physical therapists have not increased the risk and these adverse events occurring, including the inappropriate imaging referrals. So when we look at all of those systematic reviews that had already been done, we took away a few common themes from each of them. First, it became very apparent, and I think all of us know this, musculoskeletal disorders are a big deal. In fact, they are the primary reason for years lived with disability worldwide. Not only that, but like I had mentioned before, MSKDs are becoming more and more prevalent all the time, and it now accounts for 4 of the top 12 diagnoses seen in primary care. So the combination of how much this impacts the daily lives of all of these people through the world, the United States, our local communities, and how many of them are going to see these different primary care providers who are already overburdened by the number of patients they have to see and the lack of support that they're receiving. We know that it continues to increase the burden on these providers and the healthcare systems that are directing the care. Another thing that we took away is that physical therapists are pretty good at practicing in this role. We're utilizing health services appropriately, we're utilizing them judiciously, and on top of that, we're achieving similar, if not superior, health outcomes without any increased risk of safety events occurring. So, all of these things point towards us being in these roles. And after reading through the information that we gathered, we identified that there's only been a couple meta-analyses, and none of those meta-analyses only looked at randomized control trials. As we continued to look at the research that was out there, we felt like there were probably enough randomized control trials available to conduct a study like this and be able to potentially run a meta-analysis on that. And of course, we would want to try and target the highest level evidence, so that's something we wanted to go after. In addition to that, there hadn't been any meta-analyses that were performed on the outcomes of clinical imaging rates, which is exactly what we're here for tonight. Not only that, but also prescription medication rates and health-related quality of life. So those 3 specific outcomes, which we were very interested in, had not been investigated yet. So that was kind of the literature review that we went through up to this point, and we decided that we wanted to try and address these significant gaps, particularly because we practice in this specific role, and we wanted to investigate it a little bit further. So I'm going to hand it over to Bremen now, and he's going to take you through the specific project that we worked on.
Yeah, thanks, Dallas. Really great job introducing our study and the literature review. I just want to say thanks to Bruno for having us here. I don't think that there's anybody in the PT world who can just get me more stoked about what we're doing with imaging, and he's just a galvanizer to his core. So thank you so much for just leading the charge, Bruno, and bringing us on here today. And of course, thank you to Dallas and Mitch for this project. So like Dallas introduced, my name is Bremen, but I'm going to take you through kind of the rest of our study here. So all of that literature review brought us to a point of this question: how does first contact physical therapy compare to usual primary care? And we got a lot of this information from the previous really well done systematic reviews that were performed. However, like Dallas said, none of them were performed just on randomized control trials, and then none of them performed a meta-analysis on some of these really key outcomes that we're looking at today. So our outcomes were split into 2 different buckets. They were split into our societal outcomes, which included clinical imaging, prescription medication rates, and cost, and then into more of the clinical side of things, including pain, disability, and health-related quality of life. So as we've talked about, systematic review and meta-analysis of strictly randomized controlled trials, when we were looking at these different articles that we were going to try to include in our study, we wanted to highlight a few things as inclusion criteria. So as Dallas said, only patients with musculoskeletal disorders, to be able to be more specific to one type of disorder, was one of our inclusion criterias. The second one, I think, was one of the most important ones that we wanted to include. The PT had to be the director of the plan of care. A lot of the studies that we were looking at were comparing physical therapy to usual primary care, but the PTs had to follow a standardized protocol, or they had to follow specific guidelines, which did not capture the primary care setting or the first contact utilization of these providers. So we excluded all of those articles. In the articles that we included, the PT was the director and it was the leader of the plan of care, which I think is really effective in answering our question. As far as imaging goes, PTs had to have imaging privileges, either directly or indirectly. And what we mean by that is directly is what you typically think of when you think of any sort of imaging referral. As a patient comes in, the PT determines that that patient requires some sort of imaging and they directly order it. Indirectly is a little bit different, and we can maybe talk about it afterwards. It's something we utilize at Sanford Health, but indirectly is where maybe the PT can't order it due to policy or certain limitations of that healthcare system. But in these studies, the PT was able to recommend imaging, and then a different provider would actually put that order through. So the PT was still guiding that imaging, however, they weren't able to directly order it. As far as other aspects of the imaging utilization, we also included retrospective healthcare data, which means that at the final follow-up, the imaging was evaluated for all of the patients in both groups, in the first contact physical therapy group, but also in the usual primary care group. And they looked at the frequency of imaging that was utilized to see if it was more or less frequently used in either group. Just continuing off of our methods here, we have the flow diagram of studies. We found many studies, but of course, through some of our inclusion criteria, we ended up excluding quite a few of them. We started with over 300 after screening the titles and abstracts, but only ended up with 10 that were included in our review as a whole. And furthermore, only 4 studies were included in the actual clinical imaging meta-analysis portion. So I get to go through this beautiful forest plot here. So if you're not familiar with this, I'm just going to give a brief explanation of what we're looking at here. This is the visual demonstration of the meta-analysis, statistical analysis of our data. So like I said, there were 4 studies included. You can see those on the left-hand side of the screen here. Dacre, White, Gagnon, Ho Henriksen, and Oja are the authors of those studies. And sort of in the middle of the screen with the blue squares, the blue square, the size of it is the weight of the study. So based on sample size and some other factors. And then the green triangle at the bottom of the screen, that is the cumulative effect of all of these studies. So that's the importance of the meta-analysis is, can we pool multiple different studies from different areas of the world, and can we try to get an overall effect size? So when we're looking just at the diamond, as far as the diamond moves side to side, that's the confidence interval. And if that doesn't cross 0, that means there is a significant effect. In this case, favoring first contact physical therapy over usual primary care. Now, the green lines that extend past the little pyramid, or the little diamond, excuse me, are the prediction interval. And what that tells us is that's even a more conservative assumption of the effect. And that still didn't cross 0, meaning that we can be really sure in our findings that this was significant favoring the first contact physical therapy group. Another thing to highlight from this forest plot is the heterogeneity. The I-squared value was really low in this, which was basically looking at how different are the studies and how can we take inferences from those studies based on that value. When it's really low, it tells us that the studies were very similar in nature, which increases the assurance that our findings are telling us what they're telling us. So that's our forest plot. And here, let's get into the numbers a little bit. So we calculated a log risk ratio through the forest plot, but we back calculated it to a risk ratio. And patients who saw the first contact physical therapist first were 45% less likely to receive diagnostic imaging. And that's both ordering and indirectly ordering, but also retrospective healthcare data. So not only did our first contact PTs order fewer images, but they also just had that effect on the patient's whole plan of care, where if that patient were to see the usual primary care provider first, they would be much more likely to receive imaging at any point during their plan of care, not just the initial evaluation, but also at follow-up. So we also had other outcomes that I think are exciting to share as well. For example, prescription medication rates, it was 70% less likely to receive a prescription medication if you had seen the first contact physical therapy group as well. And then for our other outcomes, for example, cost was actually equal to the usual primary care group, which was a little bit surprising because of the previous 6 articles that Dallas had highlighted showed less cost with the physical therapy group, but we didn't corroborate those findings. Other outcomes of pain, we were equal to usual primary care. Disability, we were equal. And also health-related quality of life, we were equal to the usual primary care group. So the conclusions from this study, this really adds to the evidence supporting that PTs should be in this role. When compared to the usual primary care group, we utilize significantly less imaging, we prescribe less medications, and we achieve similar, if not superior, clinical outcomes for these patients with musculoskeletal disorders. As Bruno would say, a no-brainer. There are some limitations to our study, including that there were a limited amount of randomized control trials. I think further research should be performed to strengthen studies like this, as we did only have 4 for our clinical imaging meta-analysis. Another limitation is this isn't specific to one type of musculoskeletal disorder. We can't necessarily say one specific body region more than another, because some of the studies included osteoarthritis only or spinal disorders only or things like that. So we can't be super specific to one type of musculoskeletal disorder. There were other studies that we were not able to find data from, or we weren't able to get data from the authors for. And then in some of the outcomes, heterogeneity and risk of publication bias were present. It was clear that in the imaging one, which is the one that we were most excited to share today, that heterogeneity was not a significant contributor. So the clinical relevance here, PTs are an important contributor to our primary care systems to reduce that burden that Dallas was talking about earlier. We really feel strongly that our advocacy efforts should focus towards improving imaging privileges for PTs at both the federal and the state level. At the federal level, it's clear that the Center for Medicare Services does not acknowledge physical therapists as a primary care provider for patients with musculoskeletal disorders. And that flows all the way down into practice, that as we have noticed, there are so many barriers. Our advocacy efforts should definitely focus towards imaging, but also all sorts of other aspects of clinical care that physical therapists are.
We
I think,
lost.
yeah, I think we lost them.
They'd
Let's,
both been
He's back.
frozen for a
Back.
while.
Am I back?
oh, they're
You're back.
back. All right. We can always edit this. No worries. Keep on.
I'm
Let's reshare.
How far did I get?
Dallas, you,
Yeah, you were just transitioning from the federal to the state level, Bremen.
Okay, very good. Okay, so back to state level then. I think that this is where I should let Dallas take back over. So it's a pretty good segue. My computer was telling me that it's enough time of me yapping and get back to the guy who actually knows what he's talking about. So let's get to Dallas with the state level. There's, as Bruno kind of teed up earlier, there's some really exciting findings at the state level for North Dakota.
Yeah, thanks, Bremen. And something that I wanted to just remind everybody of, and Bremen and I have had to be reminded of quite a few times by our advisor, Mitch Wolden, is when we do a study like this with physical therapists being in these different settings that maybe aren't as readily applied, is we don't necessarily have to show that we're better than everybody else with all of these outcomes. Of course, we want to, and when you run the meta-analysis, you hope that it populates that way. But if we can show that we achieve similar outcomes, that's a win as well. We know that these different provider types are overwhelmed with everything that's going on. And so even if we can provide care that leads to similar outcomes, I'll quote Bruno again, as Bremen did, it seems to be a no-brainer, right? So yeah, thanks for setting up the state legislation here, Bremen. Over the past year, I've learned a lot about the legislative process, and I've had the opportunity to be a part of the Legislative and Bylaws Committee here in North Dakota. And Mitch Wolden, as Bruno had mentioned, Scott Brown, they both have helped me learn a lot about this entire process. But through the support of this Imaging SIG, I don't know how many times I contacted Bruno through the whole experience. to get some guidance from him through the support of our state board, the APTA North Dakota, our lobbyist, and several other contributors. I probably miss individuals if I tried to name everybody off, so I won't do that. We were able to get full diagnostic imaging privileges in this last legislative session. It was a really enjoyable process and at times a bit of uncertainty, but turns out we didn't have a whole lot to worry about when we saw the votes come across the board, as there was extreme favor in this legislation. So I'll just briefly read through some of the changes that had been made from the previous North Dakota Century Code. Here you can see at number 1, a physical therapist may order diagnostic imaging if the physical therapist holds a doctorate of physical therapy or has completed a board-approved formal medical imaging training program. Now, this is similar language to the previous bill that we had, but it only included plain film radiographs at that time. I did want to make one point here. During one of the testimony sessions, one of the, I believe it was representatives, I don't remember who it was exactly, but one of the things that they had concerns about was somebody who can take a weekend course is all of a sudden getting the same privileges as somebody who has a doctoral degree. And he kept going back to that concern of his. He didn't understand how somebody could take a weekend course and that would be equal to a doctoral degree. But a couple of things that we had talked about looking at it and reflecting on that conversation was we've had the military for over 50 years doing this before any doctoral degree, before master's degrees were the requirement. And not only that, but people also tend to forget how knowledgeable Bachelor of Physical Therapists and Masters of Physical Therapy are with the musculoskeletal system. It's not like somebody's coming off the street and taking a weekend course. It's somebody with vast knowledge of these systems that are completing these board-approved courses. And on top of that, it's just interesting to see how the credits and how many hours these credits in school add up to be. One credit, and I'm sure there's some variability, but here at UJ at least, is about 16 hours of didactic curriculum. And for DPT education requirements, it's 1 credit that is required. And so when you look at a weekend course, it might be around that 16-hour time frame. And when you look at the curriculum requirements, it might be about the same. So there's a lot to that question or that concern that the representative had. But I thought Mitch Wolden and Scott Brown did a great job responding to it in the moment. And because of their responses, we see ourselves here today. The last thing that I wanted to mention was number 2 here on this new legislation is that a physical therapist ordering diagnostic imaging shall report the results to the patient's designated specialty or primary care provider within 7 days of receipt of the image to ensure coordination of care. Unless the patient does not have a specialty or primary care provider, or the specialty or primary care provider received the images from the healthcare professional who performed or interpreted the images. And some of this is kind of piggybacking off of the process they took in Iowa, if I'm not mistaken, where they're reporting some of these results to the different providers. And at first it was like oh man, we really wanted full autonomy in this and be able to just take handle of it and take hold of it with our patients. But as we continued to discuss this little nuance, we were almost more excited that it was in there because it's going to improve the interprofessional communication and quality of patient care. So it's really not a bad thing. It might add a couple minutes of extra work for somebody, but when we think about the quality of care, it actually is going to improve that quality of care. So overall, we were super excited to see this pass, and come August 1st, I believe it's going to be in full force. So then it's just up to the different healthcare systems, organizations, and private clinics to be able to integrate this new bill. So yeah, really exciting to see the process over the last year with this legislation and see it come to fruition. Now with that, I think it wraps it up. Unless you had anything else to add, Bremen, I think we open it up to questions now, right, Bruno?
Yeah, we certainly do. Thank you so much. I want to get to Chuck Hazel, but first I actually just want to acknowledge, Mitch, are you still there? Can you unmute yourself, or maybe you're just grabbing, maybe you're eating dinner. All right. He's gun shy right now. It's all good. Chuck Hazel, what you got?
A question on looking at the imaging referral rates. One of the things that I had run into in digging into this kind of data across lots of different studies is that very often physicians are the way that imaging referral rates for physicians is reported. It's different. It's by per visit, for example. And some of the studies. And if we look at those in PT, we typically don't think in that context. We think more episode of care kind of context. So what was it your inclusionary and exclusionary criteria that got you around those kinds of issues? Or how did you manage that?
Yeah, it's a great question, Chuck, and something that I think we continued to learn about as we were reading through these different studies. From a practical standpoint, I think you're right. In the clinic, oftentimes these providers might be seeing the patient once in a long while. They might see him once a year, they might see him a little more frequent than that. But for us, we're seeing a patient a little more frequent, at least for the episode of care. So I could see how the common reporting of the data might be per visit versus per episode of care. For us, the specific randomized control trials that we looked at with clinical imaging, there were 4 of them. We used our inclusion criteria as the standard for how we investigated those things. So typically what we saw was in the randomization process, you were randomized to usual primary care, which could have been any type of provider other than first contact physical therapy, and then to first contact physical therapist. And then some cases in that session, the physical therapist would order an image and that would be tracked. In other cases, that physical therapist wouldn't be able to order the image directly, but indirectly through communicating with a physician or whoever that might be. And that would be counted as an image tracked for that physical therapist. And then in other situations, it was that retrospective data. And so maybe nothing happened on day 1, but when we look at it from the next 3 to 4 months, which is where our time frame was, if they had gotten an image and were first seen by a physical therapist, that would have been tallied up towards the physical therapist. So in some of these settings, the physical therapist wasn't seeing the patient through a full plan of care like you might expect an outpatient physical therapist to be doing. They might have only had contact at that first point, and that's probably the most common situation we found ourselves in. So I don't know if that answers your question, but that's probably what I would say to it.
Yeah, I think it's what you included in there, but what I was looking at is if you looked at referral for imaging rates across all kinds of studies, those retrospective reviews, et cetera, that's when you tend to run into how they would report the data. It would be so it got to be really difficult to compare rates because you weren't using a common measure, right?
I see what you're saying, Chuck. Bremen, you were about to say something.
I think the difference, Chuck, correct me if I'm wrong, but I think the difference is with these type of studies that we're looking at, it's a direct comparison. And so their data collection methods were very similar for either group because that was their goal, was to compare the 2 groups. And so when we're looking at that, we weren't taking studies that were only physicians or only physical therapists, because I think that you're right that there would be a really big challenge in just comparing rates there. But they utilize the physician, either the primary care or the FCPT, kind of as the guide of the plan of care. And so when they were collecting that data, they reported it in the same way, where they would have their initial follow-up or their initial evaluation and then a follow-up, and then there would be a column in their data that said frequency of clinical images or something like that. So I think that that's where it was really easy for our study, was because the randomized control trials that we were looking at were doing direct comparisons and they were trying to make it apples to apples, versus if we were to take 10 utilization studies of PTs versus 10 versus physicians, I think that would be a huge challenge. And I'm not exactly sure how one would do that. But that's a really, really good question.
Great. Thanks so much. Guys, this was really, really fantastic. And I loved how you drilled down on the brutal facts of physicians, frankly, becoming overwhelmed by the caseload, musculoskeletal dysfunctions, all kinds of stuff that we should be, it should naturally be offloaded to us. That should be something we advocate constantly. Sometimes we forget to tell them why we're doing this and why this is needed because they can't handle it. Their gut reaction in legislative attempts or whatever, it'll be, no, no, we can't possibly change from the status quo. Is like, I get this sense, I don't know if you guys got this when you saw this kind of for back that up. Remember the recent scare that, CT scan will elevate the likelihood of developing cancer as well. This is a recent study. I mean, in the light of all this stuff, and then we've got 45% reduction in imaging referral because we're involved, and showing that there's a remarkable record of safety, just fantastic. Do you feel that and including all these just horrible shortages, and they're only getting worse. And of course, we're all aging, not me. Um, but do you feel like, guys, do you feel like there's inevitability in this? They're going to come around sooner or later, and they're going to because this is like it's too bloody obvious. Throw that to you.
Man, I hope so. I mean, just from a very brief history, I mean, I haven't been doing this very long, but in just the short couple of years I've followed the imaging SIG, that map has really started to look a little bit more green.
Yeah.
So I would really hope that there's some inevitability. I talked about it a little bit of like the federal and Center for Medicare acknowledging us as primary care providers. I don't know what the path towards that is going to look like. I know that you've talked to me a little bit about that, Bruno, and that's one of your main goals in your tenure here as president. But
Yeah.
I think imaging is one of the most likely ones to come about. I think that the complete acknowledgement of PTs as a true first contact or primary care provider will probably be a little bit slower. But I think there has to be some level of an inevitability, especially with all the success we've had in states like Iowa and now North Dakota and some of the other
Yeah,
imaging.
and it's typically one. It's having a good partner in each state with the vim and vigor, like Elizabeth Sargent, for instance. And just to ride that out, it's surprising how much just some spearheaded advocacy will move mountains, frankly. So I really do want to tackle CMS. I think that falls, it all falls. We're just getting a little delay from APTA leadership in terms of wanting to get totally involved with it. I'm okay with that for the moment, but ultimately that's where I want to go to. And frankly, with the research that you guys presented as well as Aaron, Kyle, and colleagues, I mean, this is the type of stuff is like, you're all enough is enough. This is silly. And it just takes stronger voices. And I'm noticing that our advocates are getting way better at this. And it just takes a couple of dress rehearsals at the legislative level and realizing we have to formulate better questions. And we just have to do a little game prep, and we're getting better at it. So we're no longer being I notice I feel like the tones change from us being a supplicant to an actual person that says enough of this shit, frankly. Oh, sorry, I swore. Sue me. Um, just getting back to, it was interesting. Speaking of advocacy, sorry, I have to bring it back to this because what you guys did was just nothing short of inspiring in North Dakota. Um, the Dallas, you mentioned that guy, the base of there was a state senator that kept on going, I just can't get over the fact that you can do a weekend course. And and Mitch was so repeatedly pleasant and his decorum was excellent in trying to fend that thing. It just couldn't get it through his skull that it's like, well, hang on a second. The people who have the BSPT, have probably done this for 25 years with an enormous amount of experience and acumen. And I'm going like, so what if it's like a weekend course? I think that, I mean, but it made me realize that when I saw that, I said, that's going to be our problem going in the future. We have to prep that question so we can just blast it out of the water. But I just love I love the fact that it's just showing these remarkable, it shows up as the safety concern. So it's always going to be the safety concern that's going to be thrown in our face. But if we have these facts, it's like, look, I think those are the couple of things. Safety concerns are what we have to address. And then, and frankly, the growing shortages, and we're not giving care to our it's all about the patient, right? It always comes back to it. Are we caring for them adequately? So that's all I gotta say. I'm so glad you guys came to present this. Doug White, you got your hand up.
Yeah, thanks, Bruno. So I just want to say that, I've been in the House of Delegates a lot of years, and this year we got uh, changes to the diagnosis position, changes to the pharmacology position. Um, Last year we got primary care through and entry-level provider contact. All these motions that go hand in hand with what we're trying to accomplish here with the imaging SIG. And um, fortunately, we get enough votes to do that. But there's a lot of people in the House of Delegates that just don't get it. They're not aware of what's going on. So I would encourage all of you to run for a delegate position next year. We need people speaking who are on the forefront of all this, who can speak from experience, and to convince your fellow delegates to support these initiatives. And if you're not a delegate, look at the motions as they come up. I'm sure Hawaii will be presenting some important things next year. And talk to your delegations, your state delegations. You got to support this, and this is why, so that we don't lose in the House of Delegates when we're trying to advance our own profession. So
Thank you
my
for that. That's
soapbox.
really sobering. And yeah, that's true. And you know what? It isn't that difficult to run. You just got to do it. Here's another thing, and thank you for it. Yeah. State board positions. Any one of you. Okay, Allison, maybe you're gonna have to wait a couple of years. Uh, but there's some people on the state. Look, I've sat in on a few state board meetings, and there are some people that clearly don't belong. I remember one question was posed to an inquiry posed to about imaging, and that was quite a specific question. And the chair of this board, her concern was that in this cleverly crafted question, well, what if there's pathology on the report? The I'm quite really, this is a question you're going to ask, and you're the chair of a board. I just said you don't belong. I didn't say you don't belong here, but my cartoon thoughts here were going, wow, you don't belong here. You need to go. And here's the thing, there's a lot of those out there. A whole bunch of you can do a state board thing. It's not magic. You don't have to have drinks with the governor on this. No one wants to do it because they don't know how to do it. Just get on it. It's a cush job. We submitted a question. Is there, wow, this question came up. This is really interesting because it's a question based on prohibition, but I just didn't read it. And frankly, I really didn't. I had to look at the Practice Act 5 times because I really didn't know it. The chair of the board. I'm not naming states, okay? I'm just saying, spread it. If you know somebody kind of just, it's a cush. It doesn't take much. This is an easy gig. What I'm doing now and what y'all are doing is a way tougher gig. So if you're interested, get involved, become a state board member, because these are the people fielding the questions of the public for the public, and they're keeping us from being at the top of our game and top of our license at the detriment of the public. So that's what I'm just to dovetail with you, Doug. This is think about it. Anybody listening out there, think about putting your name in the hat because that's the only way we're going to get change. We've got to turn this over. Luckily, just between you and me, North Dakota, no, North Carolina had a pretty seismic shift in their the turnover in their state board. So this is probably, wink wink nudge nudge, going to turn to our benefit. So anyways, that's enough of that. Any other questions for our dear guests?
Bruno, there's a message in the chat for you.
What is it?
It's a question from Hunter. He's asking, in states like North Dakota, where physical therapists are authorized to order imaging, is there any specific language in the legislation that addresses whether DPT students under supervision are also permitted to order imaging?
Wow, good question. Anybody want to field it? Dallas, you unmuted.
There's probably somebody else more equipped to answer that question than I am, but I'll take a stab at it. How I've seen it practiced in the setting that I work, if students are under direct supervision of DPT, then they have the right to do that under that DPT. So that's how I've seen it practiced.
I love that. Here's another
That's
question.
generally how it's done. The CI it's under their license that everything goes. Yeah.
Okay. Love that. Question. So you mentioned, and this is to all academicians, how many people, how many practicing physical therapists know how many times they requested imaging for a patient and how this data is lost? Is there a possibility to have this type of study happen nationwide to say, hey, we're already doing it? Is that easy data to collect? One, two, question. Now that North Dakota's got this privilege, what do you think? Are people thinking about making sure we have some sort of a repository or record or some analysis of the way we're referring to obviously support our cause? So one, indirect referrals. Is there a study there that can be done to show we're already doing? And two, what are we doing in North Dakota to track our results?
In my mind, the first question, when I think about it, it just sounds like it would be a qualitative understanding of the PT experience. I don't know, at least I can't think of any way how we could actually capture, how many times are PTs messaging providers and saying, hey, I'm seeing this, can you order X imaging? But I think that would be a really interesting piece of, even if it's just survey data from PTs across the nation, of on an average week, how many, or a month, how many times are you indirectly ordering imaging by messaging the provider, and then how frequently does it work? I think that would be a really interesting study to see, unless Dallas, you've thought of that at all, or if you can think of any other way to study it. But
I think it's harder than I would maybe initially think. We tried to do something similar to that, Bruno, here, North Dakota, Salmon Health, with Epic data. And they pulled the records retrospectively and tried to figure out if indirect referrals to imaging occurred that way. It was really challenging. And then another potential way to do it prospectively or retrospectively would be for PTs to track when they referred for an image. That becomes really challenging from a compliance perspective as well. So those are things that come to my mind on that. Again, there's probably somebody else on this call that's more well equipped to answer than me.
Okay. And second question. Chuck, please.
I was just going to mention some of these questions actually go toward the study that Bill Boycenault and I are doing right now, with assistance of 3 of the students at UK. We're looking at how imaging is incorporated into clinical education, and we're doing that in 11 of the states that have a longer track record of imaging referral. And some of the questions that were being asked were actually related to the questions that are in the survey. So our data collection is about to close. With Bruno's blessing, we'll probably be looking at a webinar like this late 25 or early 26. Once we get the manuscript written.
We want the first look. You have to grant it to us. I want the first look. I don't want anybody scooping us on this. Other follow-up question, guys. How are we going to follow this data now that you got this amazing privilege that you fought and won for? Fought for and won.
From my understanding, statewide, there isn't anything necessarily, but Sanford Health, which is a big player in North Dakota, we are going to be tracking that data pretty closely. So
Oh,
now that we
nice.
have those direct privileges, using Epic data, EMR data, and everything becomes a little easier, and we are going to be tracking that
Oh,
individually as well.
I love that. That's great. So good. Okay, folks, I'm going to let you be for tonight. I'm going to Devo right now. So that's kind of important. Can you believe they're still performing? That's ridiculous. But why not? Hopefully they don't break a hip on the stage. So, anywho, um, loved it. Really great. Dallas, Ehrmantraut, Bremen Abuhl, and everybody. Charles, great to see you. George, thank you for being here. So, Elizabeth Sargent, and all our fighters out there. Annette Karam, thank you so much. We'll do this again. There is a special edition release. It's not going to be a meeting, but I'm going to re-release a meeting and an interview with Scott Rezak, who basically trailblazed a path to imaging referral in a silent state in his rural practice in Colorado. We entitled it Colorado PTs are ordering imaging and the sky has not fallen. But I think what has fallen, the message isn't clear. This really was a primer, frankly, a blueprint on how to go about ordering imaging in a silent practice act. It's based on creating a relationship with an individual radiology clinic and moving from there and building your relationships. And this is something physical therapists have to do. This is what I'm doing. We build relationships. We start to build alliances. We get out of our silos and go forth, and really aggressively, like y'all are doing. So anyhow, I wish you a wonderful evening and hope to see you potentially in a couple of months. And please give me your data. We are dying for it. But wow, this bit of metadata, which is fantastic, it's going to really, really be important to our advocacy efforts. So once again, thanks, Doctors Ehrmantraut and Abuhl, for joining us. We are deeply honored to have you, and we wish you all a good night.